Hi everybody, welcome to UWorld's Next Gen NCLEX review session. We're so glad you guys are here. Happy Thursday. We are going to kind of jump right into things here. I'm going to just talk a little bit about what we're going to be discussing today. But welcome, my name is Jackie. I'm a nurse here at UWorld. We're here in May. We're kicking off Mental Health Month. So if you missed us on Tuesday, we talked about common psych disorders. Today we're going to talk about those medications that go along with those. So if you missed Tuesday, you can check us out on demand on YouTube and Facebook. For all of our friends on TikTok, make sure you guys share this session right now. Let your friends know that we're on here. We hope we'll have more nursing students on. The more the merrier. We want to help as many of you guys as we can. And make sure you guys use that chat today. We have our content experts moderating it. They're here to answer any questions you might have. So make sure to jump in, use that. Let us know where you're coming from. But we will kind of just go ahead and get started. So again, today we're going to be talking about psych meds. We're going to do some questions throughout, and then a little preview into next week. We have Nurses Week. So we're going to have a full week of content on our lives for you guys. So make sure and subscribe to your favorite channel so you can see a kind of a lineup of all the content that's to come. And we're excited to celebrate all of you, celebrate our fellow nurses, and it'll be fun. Okay, we're going to jump in. So psych meds. We're going to talk about, on Tuesday we talked about anxiety, depression, and schizophrenia. So today we're going to talk about the meds for these conditions. And I wanted to have like a little disclaimer. This isn't a full encompassing list, but these are like the big heavy hitters. So hopefully this will be like a good starter for you guys. But it's pretty significant. I hope we're going to get a lot out of it. But again, it's not everything that you're going to need to know, but a good start. Okay, so for anxieties, we're going to cover benzodiazepines. For depression, we're going to cover SSRIs, SNRIs, and MAOIs. And then for schizophrenia, we're going to talk about antipsychotics. So we'll do a question at the end of each of these chunks and kind of walk through them that way. So to kick us off, we're going to take a visit back to our neurotransmitters that we talked about. So we have an image we're going to pull up for you guys just to give you a visual. But again, before we kind of get into all of these meds, we're going to go do a little quick refresher on neurotransmitters that we talked about on Tuesday. So serotonin, norepinephrine, and dopamine. So serotonin helps us with our mood. Norepinephrine is a kind of plays a pivotal role in our fight or flight response. So it's kind of like our activator. And then dopamine is responsible for our feelings of pleasure. So low levels of these neurotransmitters are going to be linked to like depression and other conditions like anxiety. So knowing this, there's going to be some overlap with our medications that we use to manage anxiety and depression. Okay, we also learned that variable dopamine levels kind of resulted in our schizophrenia symptoms either being positive or extra or negative, which would be like deficits of the neurotransmitter. Okay, so that's our little quick stroll back memory lane, down memory lane of neurotransmitters. Let's jump into benzos now. So we're going to bring up a table for you guys. Again, the whole point of this, it's just to give you some quick study tips. Feel free to screenshot it. We hope it can be helpful. Again, you can have access to it. And if you want to listen again to this, this will be on demand later today. So, okay, anxiety, benzos. We're going to start with these. These are going to be the meds that we give for our like acute phases of anxiety, not our day-to-day. So these are going to be kind of in the when we need a quick fix for an acute exacerbation of anxiety. So our main theme when we talked about anxiety was like calm. We need to be calm. We need to help calm our client down. So with this in mind, we're going to, in addition to like serotonin, norepinephrine, and dopamine, another transmitter that we're going to introduce is GABA. So GABA is an inhibitory neurotransmitter. It's going to tell our brain, be cool, stay calm, you've got this, and it's going to slow everything down. So the mechanism of action of benzos is to increase that effect of GABA. So by doing this, our brain activity is going to slow down. It's going to go from racing and being excitable to kind of being cool and calm and slower. So it's going to reduce that anxiety. It's going to make us sleepy, and it's also going to prevent seizures. So when we hear excitable brain, we worry about seizures. Okay. So that is the mechanism of action. Now we're going to move into some examples of this and kind of tie some of these medications you might have heard to this drug class. So benzos are going to be our LAMs and PAMs. So you can kind of follow along too in the table, but for your NCLEX, and typically for nursing school, you're going to need to know like the generic name, but I'm going to tell you the trade name just to help make some more pathway connections for you guys in your brain. So examples of our PAMs are going to be lorazepam, which is Ativan, diazepam, clonazepam, which is Klonopin, and then our LAMs are going to be alprazolam, which is Xanax, and midazolam, which is Versed. And we use Versed a lot when we're talking about anesthesia. Okay, so those are some examples. Let's jump into what we need to know for some of these adverse effects, and then that's going to lead us into like our safety and teaching. So we need to know what can go wrong, to know what to observe for, and what to talk to our clients about. Okay, so adverse effects of benzos are going to be related to that slow and sedation that they cause, because it's not just our brain that's slowing down, it's going to be our whole central nervous system, and we know that impacts essentially everything else, every other kind of vital component of our body. So they can cause respiratory depression. So we need to think along the same lines as narcotics when we're looking for some of these adverse effects. So we need to worry about protecting our airway, making sure we're breathing. They're also going to cause like sedation and drowsiness, which is going to increase our risk for falls. So another big safety thing there. We need to make sure our clients are not trying to get up and move, and if they are, we need to help them. We also, for benzos, kind of like our last but not least adverse effect, over time, these medications can lead to dependence and significant withdrawal symptoms if we stop them abruptly. So we need to be able to monitor for how clients are taking these and know how to support them if they're transitioning away from them. Okay. Last part of benzos, safety and teaching. So overdose on benzos is very common. So we need to be able to recognize what this is going to look like. So what extreme sedation and respiratory depression looks like. And then we need to know there's an antidote for them. So the antidote for benzos is called flumazenil. And so this is a GABA antagonist. So it's going to reverse the action benzos have on GABA. So it's going to kind of bring us back up. So equally important, we need to always think about the ABCs when we're thinking about overdose, and we need to make sure our airway is protected. So especially in these clients, since respiratory depression is likely what they're experiencing, these clients are likely going to need to be intubated. So we're going to be outsourcing breathing to a machine as these clients are recovering. So kind of in the same vein as respiratory depression, we want to teach these clients to avoid combining medications that are also CNS depressants, like alcohol and opioids, that can kind of worsen or potentiate those side effects. And we also want to give special consideration to some of like our elderly clients or clients with COPD that are taking benzos. In clients with COPD, it can really worsen respiratory depression and cause worsening hypoventilation and hypoxemia. So it's going to decrease our respiratory drive, which is going to cause more problems in an already compromised respiratory drive in clients with COPD. Okay. Our third of the way through, we're going to bring up a question, check our understanding, see what we learned. I'm going to read the question for you guys, and then I will let you answer. I'll check the chat, and then we'll walk through it. Okay, so we have question 1. The nurse is caring for a client who is experiencing hypotension and respiratory depression after receiving IV midazolam. Which of the following medications should the nurse anticipate administering to the client? Option 1, benztropine. Option 2, acetylcysteine. Option 3, flumazenil. Option 4, phentolamine. These are a mouthful, that's for sure. Okay, let's see what we got. All right. seeing a lot of answers come in already. Good job, you guys. All right. Instagram, I'm seeing a lot of right answers. Facebook and YouTube. Good job, you guys. Wow, it's flying. I'm also seeing where everybody is coming from, and you guys are joining us from all over the world. So that's awesome. Thanks for being here. All right. More coming in from Instagram. Good job, you guys. All right, perfect. And I'm seeing some TikTok come through too. Good work, good work. And don't forget, it's not too late to share this live stream. So if you're on TikTok, make sure and share. Get your friends here. Okay. All right, so you guys, a lot of you got it. The correct answer is flumazenil. So kind of walking through all of this, we see in our stem, they're talking about midazolam, which we know is a benzo. They're experiencing signs of too much of this, some respiratory depression and hypertension. So we need to recognize this is a situation we need to reverse the effects of. So we're going to give an antidote. And so that option is option 3, flumazenil. Option 1, benzotropine, is an anticholinergic. So this would be used to treat some of our like EPS side effects, extrapyramidal symptoms. And this is more associated with antipsychotics. So we're not going to do that one. Option 2, acetylcysteine, is used to treat acetaminophen poisoning. So that's not going to be our right answer. And then option 4 is phentolamine. And this is a alpha adrenergic receptor antagonist, which treats tissue necrosis. So this is also not a right answer. So you guys got it. Option 3, good job. Okay, we're going to jump into our next big topic, which is antidepressants. So we have another table we're going to bring up for you guys, and we're going to walk through this, and we'll do another question at the end. Okay, so moving on to depression and antidepressants. These are going to include our SSRIs and our SNRIs, and we'll walk through what that means exactly. So SSRIs, which are our select serotonin receptor reuptake inhibitors, these are also used to treat anxiety. So these are going to be meds that are used like in more of the long-term day-to-day management of general anxiety. Those benzos are what we're going to use for our acute episodes. Okay, so we know the function of these neurotransmitters. Let's talk about how neurotransmitters kind of move around in the brain and what this process of reuptake means, because that name is in all of these medications. So let's see what reuptake means. So neurotransmitters are released from a neuron, then they bind to receptors, and then they are taken back up or reuptake into the neuron and either stored away for later, or they're metabolized by a component called monoamine oxidase, or MAO. And like, spoiler alert, it's the same MAO in MAOIs. Okay. So essentially, these neurotransmitters, they're going to get snatched up and hidden, or they're going to get like kind of garbage disposal. They're going to get metabolized. So selective serotonin reuptake inhibitors, or SSRIs, do what the name says. They block that reuptake of serotonin. Same idea with SNRIs, or serotonin norepinephrine reuptake inhibitors. They're going to block the reuptake of serotonin and norepinephrine. So with MAOIs, or monoamine oxidase inhibitors, they're blocking that action of the monoamine oxidase enzymes. So again, we learned that the MAOs, they metabolize the neurotransmitters. So you can kind of think of them as like a garbage disposal for a neurotransmitter. It's going to like eat it up, and it's not going to be a neurotransmitter anymore. So MAOIs are going to block the breakdown of neurotransmitters. So big picture, mechanism of action for all of these. These meds prevent the like snatching up and the breakdown of neurotransmitters, so there's more available in the brain chemistry. Something really important I want you guys to remember about MAOIs, symptoms kind of resolve not just MAOIs, but also SSRIs and SNRIs. Symptoms are going to resolve slowly. So these medications need to build up in the client to start being therapeutic. So an initial response can take like anywhere from 1 to 3 weeks to show, and it can take up to 12 weeks to see like the full benefit. So, you're looking at months to kind of see a change in these clients. So knowing this and thinking about this, think about teaching questions on the NCLEX. We have to teach these clients about consistency. Like consistency is key with these medications. And then again, kind of on the flip side, think about if you had a question where you're looking for a medication that's like a quick fix. These are not going to be it. So that's when you would see maybe those benzos as like a correct option for needing to take an immediate action. So just a little tip there. Okay. Let's jump into some examples of these. So SSRIs, these are going to, again, increase the amount of circulating serotonin. We know serotonin helps us with our mood. So these are typically going to end in like ENE and PRAM. So again, you need to know the generic names for the NCLEX, but I'm going to tell you the trade names so you can kind of connect some dots. Okay, so we have fluoxetine, which is Prozac, paroxetine, which is Paxil, sertraline, Zoloft, fluvoxamine, which is Luvox, citalopram, which is Celexa, and escitalopram, which is Lexapro. Okay, so those are some common ones. I'm sure you've heard some of these before. Okay, examples of SNRIs. These are, again, going to increase the amount of circulating serotonin and norepinephrine. These are going to end in faxine. So venlafaxine, which is Effexor, desvenlafaxine, which is Kidelza or Pristique, and then duloxetine. And I know it doesn't end in faxine, but I thought of a way you maybe can remember this. Okay, so you can remember this is an SNRI because it starts with dual, like a dual or two, so you know it's doing two neurotransmitters, serotonin and norepinephrine. I don't know. I hope that helps. Okay, and then last but not least is levomilnacipran, which is Fetzima. I don't have a good trick for this one, but if you see a very long name, know that's an SNRI. Okay, MAOIs. Side note on these. These are much less common to be prescribed now, but still really good to know the basics of them. So these are often used for like our treatment-resistant depression. So they're not a first-line approach to treating depression because they have a little bit more significant side effects. We definitely, they're not indicated in treating pediatric depression either. Same thing, due to the side effects. So some examples of these are carbaxazid, phenelzine, and tranylcypromine. I did practice saying all of these, but they're still tricky. Okay, so let's move on to adverse effects of these. So we're going to start with SSRIs and SNRIs because these are going to match up. They're going to have a lot of the same effects because they're dealing with the same neurotransmitters. So think about the 7 S's for these side effects. So suicidal thoughts. You're going to wonder, why is a side effect of an antidepressant suicide? So essentially what can happen, these antidepressants can actually exacerbate suicidal ideation because they're giving the client more energy. And so essentially they have more energy to kind of carry out maybe that suicidal ideation they have. So that's a really important safety issue we have to monitor for. The second S is sexual dysfunction or decreased libido. The third is sleep pattern changes, stimulation, so irritability, agitation. The next one is shifts in weight, so weight gain is very common with these medications. And then one specific to SNRIs is it can cause hypertension, so we want to make sure that's monitored. And then the last one, serotonin syndrome. So we're going to take a quick detour here and talk about what serotonin syndrome looks like, and we have an image for you guys too. Okay, so we'll pull that up for you guys. So serotonin syndrome is a pretty serious adverse side effect that can happen with antidepressants, and it's going to boost serotonin, any antidepressant that is boosting serotonin. So again, it's going to happen in our SSRIs and our SNRIs. So it's going to look like sweating, agitation, tachycardia. So anytime our heart's involved, that's where things can get serious. Hypertension, muscle effects like clonus or tremor, and then dilated pupils. So we want to know those signs of serotonin syndrome so that we can recognize it. And if that's the case, we need to contact the healthcare provider. So again, another thing that really kind of potentiates serotonin syndrome or big factor that is associated with it is how these medications interact with other medications. So we want to teach our client to avoid things that will increase our risk of serotonin syndrome. So herbs like St. John's wort, certain like analgesics like pain meds, tramadol and methadone, we don't want to take those. Other antidepressants that are kind of dealing with serotonin, we want to avoid those as well. And then certain anti-migraine medications that include triptan. Okay, so those are our S's. Another kind of key adverse effect to know about SSRIs and SNRIs is we don't want our clients to stop them abruptly, because if we do, our body is not going to react well. So we have another mnemonic for you guys. This one is finish. So if a client stops these medications too abruptly, it's going to look like flu-like symptoms, insomnia, nausea, imbalance. We need to think about falls, sensory disturbances, and hyperarousal. They're going to be kind of agitated. Okay, so I hope that's helpful. We're making our way through. A few other things to know about SSRIs and SNRIs is how they can affect bleeding. They're gonna increase our risk of bleeding, and they can also cause a prolonged QT interval. So again, anytime our heart is involved, we want to make sure and tell our client, and we want to let them know what they need to monitor for. Okay. We're going to hop over to MAOIs on our table there. Okay, so MAOIs, again, they're like the garbage disposal of neurotransmitters. So when we inhibit our desired outcome, again, it's increased levels of serotonin, dopamine, and norepinephrine. So because of this, just like SSRIs and SNRIs, serotonin syndrome isn't a risk with these medications. But a more kind of life-threatening risk that can occur with MAOIs is a hypertensive crisis. So these medications can cause, again, an extreme rise in blood pressure that impacts the perfusion to our vital organs. A few other kind of adverse effects that we'll walk through is how these meds interact with foods or medications. So clients taking MAOI should avoid foods that contain tyramine. So these are found in like fermented foods and aged cheeses. Okay, we're almost done with antidepressants, and we have a question. Okay, so safety and teaching. Just like we said, like our main theme for benzos and anxiety was staying calm. Our main theme for depression was safety. That was what we talked about on Tuesday. So for clients taking antidepressants, again, we need to teach them to report any worsening depression or suicidal ideation to the healthcare provider. We talked about this, but that is a big side effect of these medications. We need to emphasize that these medications should be taken as prescribed by the healthcare provider. This always seems like a very basic thing, but it's something we can never reiterate enough to a client. So again, we're trying to establish a therapeutic level of these neurotransmitters, and we don't take them dependent on our mood. So we don't take them, like if we're feeling more down, we don't take an extra dose. We just take them as they're prescribed so they can do their job, build up in our system, and kind of get to a therapeutic level. Again, linking this back to what we learned, those adverse side effects of stopping too abruptly. We want to tell our clients to never just stop taking this medication, and we want to tell them about those symptoms, that finish. Again, we want to stress the importance of avoiding other substances while taking these medications. We don't want to mix anything like alcohol with these. And then clients should also be kind of advised to discuss any plans for pregnancy as well. So talk to the healthcare provider if they have plans to get pregnant or become pregnant. Okay, we made it through our antidepressants. We're going to pull up a question. We'll take a minute, see what we learned, and then I'll read it, give you guys a chance to answer, and then we'll walk through it. Okay. The nurse is talking with a client with major depressive disorder who has been taking paroxetine for the past 3 weeks. Which of the following statements by the client would require immediate follow-up? Option 1, I have had a decreased appetite lately. Option 2, I still feel depressed even though I have more energy. Option 3, I sometimes have difficulty falling asleep at night. Option 4, I have a decreased interest in sexual activity recently. All right, I'm going to see what you guys are thinking. let's see what we got. Cool. See whatever. Oh, guys, thanks to everyone who's following us and sharing our session. We would really appreciate it. All right, let's see what we got. You guys are doing great. All right, our friends on TikTok, I'm seeing a lot of answers come in. Good job, you guys. Our friends on Instagram are definitely getting some right answers. Good job, Misty and Judith and Casey. Let's see what else we have. Facebook coming in with some good answers. Way to go, you guys. Good, I'm glad this is working. All right, I think you guys are getting it. Awesome. Okay, so correct answer is option 2. I still feel depressed even though I have more energy. So this is our right answer again, because antidepressants can kind of exacerbate that suicidal ideation. These clients are going to have more energy, and they might any suicidal ideations, they might be able to have the energy to carry them out, unfortunately. So again, that's definitely something we want to, that requires immediate intervention. That's an immediate safety concern. We need to make sure somebody is with that client and that their safety plan is kind of activated immediately. So options 1, 3, and 4, these are some of those expected adverse effects, but it's not life-threatening at this time. So again, our priority kind of big safety takeaway is option 2. Okay, home stretch. We're in antipsychotics. So we've covered anxiety, depression, now we're on to schizophrenia. Okay, so we have a table we're going to bring up for you guys, and this is going to cover our first generation and second generation antipsychotics. Okay, so first generation, second generation antipsychotics. We learned on Tuesday that antipsychotics affect dopamine and serotonin differently to kind of depending on the drug. So our first generation or typical antipsychotics, they're going to block dopamine 2 or D2 receptors within the brain. So when we talk about kind of like side effects of these medications, there's going to be a big focus on our extrapyramidal side effects and our metabolic side effects. So they're going to do things, the first generation versus second generation, they're going to be kind of like opposite of each other. Okay, so our first generation or typical antipsychotics, they block our D2 receptors in our brain. They're going to have more extrapyramidal side effects, and we're going to talk through these in just a second, compared to second generation, but they have less metabolic side effects compared to second generation. So the inverse is true for our second generation or our atypical antipsychotics. So these also block dopamine receptors, but not as much as our first generation antipsychotics. But in addition, they're going to also block serotonin. So they're often like preferred because they have less of the EPS side effects, but they have more of the metabolic side effects. But again, those metabolic side effects, they're a little bit easier to manage. So we're going to kind of walk through all of that. But regardless of like first generation, second generation, all antipsychotics help to reduce like the hallucinations, the delusions, the disordered thinking, all those hallmark manifestations of schizophrenia. And that's really like what we're after. Okay. Examples. So let's talk about examples of our first generation or typical antipsychotics. Again, you can see this on the table. We have haloperidol, lozapine, and anything ending in zine. So chlorpromazine, fluphenazine, and thioridazine. Okay, examples of second generation or atypical antipsychotics are going to be aripiprazole, and then our penes and dones. So clozapine, which is clozaril, olanzapine, which is Zyprexa, risperidone, which is risperidol, and ziprasidone. So some of these names are going to start sounding familiar to you. Again, you need to know the generic for your NCLEX and light, most likely nursing school. But again, I think a lot of times we hear the other names kind of in other vernaculars. So just to help create a pathway for you guys in your brain. Okay, so we've covered kind of mechanism of action with those first and second. We've covered examples. Let's jump into our adverse effects. So again, remember first generation or our typical antipsychotics, they have more EPS and less metabolic than second generation. So second generation have less EPS and more metabolic. So we're going to break down EPS and metabolic. Okay. So first, for EPS, think about the mnemonic ADAPT. And so these are all these kind of adverse effects. They're all related to movement. So the A and D in ADAPT is acute dystonia. So these are like muscle spasms that are going to create some of that abnormal posturing or movements. Akathisia, which is restlessness or pacing. Parkinsonism symptoms. So these are going to be things like a tremor, rigidity, akinesia, loss of movement, freezing, all of those kind of hallmark signs of Parkinson's disease. Tardive dyskinesia. These are kind of abnormal movements with our mouth and repetitive. So things like lip smacking, kind of odd movement of our tongue outside of our mouth. So those are, so again, remember for EPS or extrapyramidal side effects, think of ADAPT. Okay, metabolic side effects. Again, remember these are more common in our second generation, less common in our first generation. So these are going to be things like weight gain, diabetes, increased cholesterol. These can all occur. But again, these are a little bit more, a little easier to manage than, and a little bit, if you had to pick a side effect, these might be a little bit maybe more desirable. So that's why those second generation antipsychotics are often preferred over first. Okay, other side effects are going to be neurological and cognitive. So these can be like sedation, cognitive impairment, and then an important thing that we're going to talk about is neuroleptic malignant syndrome. So sometimes a good way to remember that this is associated with antipsychotics is sometimes antipsychotics are called neuroleptic medications. So neuroleptic malignant syndrome is going to go with antipsychotics. So essentially what happens, it's just like these medications like gone wrong. So it's an emergency, and essentially what happens, it's a reaction that causes like hypothermia, so that increased core temperature, muscle rigidity, and altered mental status, and then some autonomic dysregulation. So kind of think about our blood pressure. It usually happens like when we start these medications, or within like 1 to 3, it happens when we start these medications or increased doses, and it's going to present itself in like 1 to 3 days of that action happening. These medications can also cause some cardiovascular effects like orthostatic hypotension, and then also like that prolonged QT interval. So that's a common thing of all these medications, SSRIs, SNRIs, and antipsychotics. They can also cause increased prolactin levels. So we know prolactin is the hormone essential for milk production. So these clients can actually start lactating. They can produce breast milk. Their breasts can enlarge, and then they can have some menstrual irregularities in our female clients. Okay, and lastly, they're going to have some anticholinergic side effects. So we talked about this in another one of our sessions, but you can always remember these as can't see, can't pee, can't spit, can't go, number 2. So again, think dry eyes, blurry vision, urinary retention, dry mouth, and constipation. And then again, these are pretty substantial side effects, these EPS side effects. So you can see where some of that trouble comes in with the first generation. Okay, so last part, safety and teaching. Then we have our question and we're done. Okay, so again, because it's such a severe and like life-threatening condition, all clients need to be monitored for that neuroleptic malignant syndrome throughout treatment. So if a client develops fever or muscle rigidity while on this treatment, immediately they need to call the healthcare provider, and that medication needs to be stopped. And then we also need to teach them how to manage some of those metabolic side effects. So exercising as much as they can, taking in a healthy diet, things like that. And then, as always, we don't want to mix substances or other CNS depressants with any of these medications. So teaching them to avoid alcohol is going to worsen that sedative effect of them. And then, again, we talked about orthostatic hypotension. We need to talk about falls, fall prevention, how to move slowly from position. Okay? That was it. Okay, we have our last question, and then we'll be done for today. So we'll pull that up for you guys. I'll read it. You guys take some time to answer. This one is a select all that apply, and it's going to kind of incorporate some of what we learned on Tuesday too. Okay, so the nurse is planning care for a client with schizophrenia who is experiencing auditory hallucinations. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. So option 1, assist the client to participate in group activities on the unit. Option 2, administer risperidone to the client. Option 3, prepare the client for an EEG or an electroencephalogram. Option 4, encourage the client to listen to music. Option 5, directly ask if the client is hearing voices that instruct self-harm. All right, I'll give you guys some time to answer, see what you guys are coming up with. Awesome. Thanks, Nikki, for following us on TikTok. All right. Good job, everyone, on YouTube and Facebook. I'm seeing a lot of these answers come in. Good job, Instagram. Way to go. All right. This one's a tricky one. All right. Good job. TikTok, Instagram, seeing a lot of answers come in. Thanks for participating. Good job, everybody. All right. Okay. I think you guys are pretty close to this. So we'll walk through all of these options. So again, schizophrenia, hallucinations, and I think that was pretty much it. So how are we going to care for this client? What kinds of things do we need to put in our nursing interventions? So option 1, group activities. This is not appropriate. And I should say again, select all that apply. We're going to go through these one at a time. We kind of take a true-false approach to these. So option 1, assist the client to participate in group activities on the unit. This is not a therapeutic way to kind of treat a client with schizophrenia. We need to kind of decrease stimulus around them and work with them in a one-on-one setting. So this is not going to be a correct answer. Okay, option 2, administer risperidone to the client. This is true. This is a second-generation antipsychotic, so this is going to be an appropriate action. Option 3, in EEG is used in seizures. So this is not a correct answer. This is not anything that we're going to do for our client at this time. Option 4, providing activities like listening to music. This is true. So we want to, again, help distract the client's mind from anything, like any of that internal stimuli. So that's a true answer. And then option 5, directly asking the client about hearing voices that are instructing self-harm. Again, this is true. We want to identify if these are command hallucinations. Those can be very problematic. We want to make sure that we're addressing this with the client, asking them these questions. So our correct answers on this one are going to be 2, 3, and 5. Again, 2, 3, and, 2, 4, and 5. 2, 4, and 5, 2, 4, and 5, 2, 4, and 5. Okay, so hopefully that was helpful for you guys. Thanks for sticking with us. I know that was a little bit long, but we hope this was helpful. You guys are in that kind of wraps up what we have for today on psych meds. This is the perfect time for you guys to really start your intensive study for the NCLEX if you guys are kind of ending your last semester of nursing school and getting ready to prepare for that. We hope you'll go on to nursing.uworld.com, check out our 7-day free trial. This is an important, there's so much great information on there for you guys. You can see our questions, check out great study resources. Again, now's the perfect time. Check it out. We hope it'll work for you. We know it will. Make sure you subscribe and follow us on your favorite social media channel. We have a full week of content for you guys next week, so we can't wait to see you back. And thanks again for everything. We'll see you next time. Bye.